Welcome to Roswell, and I'm really happy to be included in this presentation, so I'm really happy to be speaking to you today. So I manage the palliative care service here, and I kind of will just go through a little bit of what we do. Because some people really get it and understand what we do, and others it's a bit obscure. So we'll start by just defining what palliative care is, because I think there's still a lot of people out there that don't quite understand what we do. Some differences between what palliative care is and what hospice is. 3 treatments for pancreatic cancer pain. So I was asked to talk about pancreatic cancer pain, medical cannabis, and goals of care discussions all in the same talk, which is 1 hour. Usually I give one talk for each of those topics that are each an hour long. So I didn't cram all that into this, but it's going to be, they're broad things that I'm going to be discussing. So we're going to talk a bit about medical marijuana and a little bit about that. And we're going to talk just a tad bit about kind of communication skills and how to have advanced care planning discussions, the differences between some of the advanced care planning documents that are out there. So that's what we're going to talk about in the next hour. Nothing for me to disclose. So purple is the color for pancreatic cancer, and I start with this just to kind of remind everybody that the way I start with a patient evaluation is really just kind of, when I walk in the room, I don't start with their physical symptoms. I usually start by getting to know who they are as a person. And the purple kind of reminds me to say that, just that, we're treating human beings who have a family, who cancer, someone I spoke to yesterday, I described cancer as a nuclear bomb that gets dropped on a family, and the patient's kind of in the middle of that fallout, and what it does to people. And we see it every day, and there's a lot of suffering, and some of that suffering is physical, some of it is emotional, and some of it is spiritual. So as a palliativist, we look at the whole person, and we function as a team. And so palliative care cannot be done by just one doctor or one nurse practitioner. Absolutely not. It has to be a team, or else it cannot be called palliative care. So what is palliative care? What is palliative care? So I like to be interactive when I give lectures, although this is a large group. But if you want to yell out what first comes to mind when you hear this phrase? What was it?
Pain control.
Pain control, love it.
Support.
That's a great word. Because our department I chair a department called the Department of Supportive Care. So palliative is within that, but so is psychology, psychiatry, and spiritual care. So all of those things could theoretically be considered support for somebody. What else?
Symptom control.
Symptom control. So yeah, basics, bread and butter, a very thorough evaluation of physical symptoms and emotional symptoms. Anything else? Quality of life. Wow, I love these definitions because no one said end of life yet. So maybe if I was giving this lecture 20 years ago or 15 years ago, you would have said end of life. And we do help with end of life care with people, but it's not always end of life care. And actually, many of the people we're seeing, especially in the outpatient setting, have several years to live. Several of them are cured from their cancer and in remission, and we treat survivors. So palliative care is not actually always hospice. Is there overlap between the two? Yes. But hospice is a wonderful service that's given at the end of life in the home generally, and palliative care kind of is given along with aggressive care, preferably earlier in the stage, earlier in the process of the disease. So hospice is meant for patients who are in the last 6 months of life. It's basically an insurance benefit that pays for people's care in the home. And so palliative care isn't linked to payment. It's not linked to a benefit or anything like that. It's just a philosophy of care that's done. And it is modeled after the hospice model, which is a team-based approach to care. So palliative care can be given any time in the trajectory of the illness, and actually some hospital systems in the nation provide palliative care right at the outset of diagnosis, which would be wonderful. But the volume of patients we have, sometimes that's not always feasible with the size of team that we have, but some places believe that you should get a consult right out of the gate, from the get-go of a diagnosis of cancer, and definitely anybody with an advanced stage. So there is a lot of overlap between palliative care and end-of-life care. So some of our patients get referred to me later than I would prefer, and some of them, when I take a look at that patient, I'm thinking this patient should actually be in hospice. So a lot of our work is trying to figure out when is it time for that service, and how can we guide the patient to figure out what's best for them as far as their goals. So when we see people, we're not of the mindset of trying to have an agenda of stopping treatment or giving anything up. I still think there's some people in the healthcare field who believe that when we get called in, that we're going to go in and talk the patient out of their treatment and talk about DNR and stopping things, and that somehow this is what palliative is all about. And to be honest, I've advocated for a lot of treatments for my patients, and often push them or kind of been their cheerleader when they're going for a treatment. Sometimes we talk about the burdens and the risks, and we talk about what's important to them. So things like radiation, procedures, Plerex catheters, all sorts of things are done to the patients that we see, and we support those things. And many patients can still remain full resuscitation status, full code, and even in hospice, you do not need to be a DNR in order to enroll with hospice. However, the philosophy of care of remaining at home and having a peaceful death usually goes along with a DNR. Hospice does not require you to be a DNR to enroll. And that was my next little bullet there. So it's always a good idea to discuss with people their goals. And this is something that is not done. Do you agree? Is this done well? So I've had patients with recent craniotomies that don't even have a proxy on file. And if we look at the advanced directives that is done, at least in this building, it's pretty much our team, maybe the ICU, the hospitalists, a few of them are doing these. But in general, the primary oncology teams are a bit bogged down with a lot of other things, and not to their, not because they don't want to, but I think that, these things take time. And that's the benefit that we have, is that we get a little bit more blocks of time. We get a larger block of time to sit with people, because these conversations, as we all know, can be touchy, they can be uncomfortable, you need to establish rapport first, and all that stuff takes time. And if you have to talk about surgery risks or chemotherapy side effects, and the person feels lousy and you're trying to get them feeling better, it's really hard to have a lot of time left for this. So, what was that? You're agreeing with me? And with 15-minute visits, especially in the primary care realm, I just don't know how I could ever do that as I am a palliative care doctor. If I was a primary care doctor, it would be very difficult to do this. But I will talk a little bit about how to schedule a separate visit for a goals of care discussion, where you can just bill for that and spend some time doing that. So I'll talk a little bit about that. So I think if there's a way to get reimbursed for our time, then that's really helpful, and there is, and I'll talk about that a little bit. That might be helpful to you as primary care physicians. So everyone should have a proxy. Even healthy people should ideally have a proxy. So I always make it a point in pretty much every patient I see to address whether or not they have a healthcare proxy, especially if they're getting toxic treatments or surgeries. If something should go suddenly wrong, we would need to know who to contact on their behalf. And this is a picture that is really famous that talks about the past and then kind of how things have been more recently. I don't know if there's a clicker. Is this it? Yeah. Sweet. Here we go. So back when I first started training, this model was kind of still in place, back in the 90s maybe, where it was just kind of like go, 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 go. Person's agonally dying. Okay, hospice, a couple days. But here, this is kind of how things have trended over the last 15, 20 years, is that, palliative gets called, ideally over here, and then we know the patient over time, and the life-prolonging care gets less, and then the palliative care gets more, and then we kind of help transition with that hospice care, and you know, a lot of times we, the palliative docs, follow the patients in hospice, and that's quite rewarding for us because we already know them for a long period of time. Meeting them to talk about their end-of-life goals, like right before they pass away, is not ideal, right, as a stranger. So how do we define palliative care? It's total care of people whose disease is not curable, chronic illness, pain and non-pain symptom management, attention to psychological, social, and spiritual problems. We get pretty deep with people. We spend a lot of time with them. Our new visits take a full hour. Our follow-ups often take half hour to 45 minutes. Why? Because we really spend the time. I try to do a lot of listening, finding out who people are as a person, and that sometimes takes a lot of time. There's a lot of anger, there's a lot of grief that we work through. So it's a team approach. Our social worker spends time with the patients. We have specialized nurses. And really our main focus is to improve quality of life. So if someone were to ask me in my agenda, I'd say it's to make you feel better. To palliate means to make feel better. And obviously we can do that the longer we know the person, so earlier intervention. And that's been actually linked to some really great stuff. And so this is a nice schematic that talks about the holistic care of what we provide, which is patients and families, quality of life, pretty much for all of the whole family. So when is it time to refer? What do you guys think? When would you think about palliative care? Referral. Diagnosis. I love it. This is so modern. Cancer diagnosis may or may not be, but definitely somebody who has progressive illness, someone who's in and out of the hospital. So, you know, if you look at kind of criteria for palliative care, there's disease-specific criteria, and then there's cancer-specific. So for cancer patients, if someone is kind of failing, I hate to say they're failing, if treatment is failing them over and over again, and they're on their third, fourth, fifth, sixth, seventh, whatever line of treatment, and then, you know, immunotherapy and this and that, and they're like in a wheelchair, you know. I mean, there's people that are quite obvious it's time, right? They're having a lot of symptom burden. They may live 3 hours away. They have family that's really stressed out. They're low social economic status. They have a lot of psych comorbidities, maybe some comorbid addiction. We see a lot of addiction in our clinic. I'm actually Suboxone trained. However, I do not run a Suboxone program here because that would be a full-time job in itself with our population, unfortunately. We see a lot of misuse of opioids and problems with that. That's a whole other lecture, and I'm not getting into that today. I'm sure you want to know about that. It's a hot topic right now. And so so the question to ask yourself is, would you be surprised if your patient died in the next year? Have you heard of this question? It's called the surprise question. Surprise. Really, a question that we forget to ask ourselves. A question that we gloss over. When I say we, even me, I sometimes don't want to think about this because it's not fun to think about that. In our culture, in our society, we don't want to think about death and dying. We don't even want to say this word. So some of my patients don't even want to say the word cancer. So my job is to get them to actually say the word and to kind of figure out how to start accepting it. And then they can actually live their life a little better. So if you're not surprised, if the answer to this question is no, then yeah, call us, please. So there's been randomized controlled trials, one published in the NEJM, showing longer survivals in certain types of cancers with earlier referrals. And this was the TEML study, which pretty much radically changed palliative. This was back in 2010. And then it got put into a ton of guidelines, and it really helped me out because I was able to kind of have a lot more leverage within my institution, because now it's part of several different ASCO and NCCN and things like that guidelines. Enable 3 is another one, randomized controlled trial that showed improved outcomes for patients who were referred earlier. And the first study was stage 4 non-small cell lung cancer patients, and the second one was early palliative care involvement for cancer patients. So if we're looking at the Cochrane review, they kind of looked at a lot of different small studies about early palliative care and does it really improve survival? And, I think at the end of the day, there's not enough of these studies to show, but we all know that we do good work for people and we help them figure these things out. So what they found was early palliative care may have benefit on quality of life and symptom intensity among patients with advanced cancer when you compare it to those with standard care alone. So there's more and more evidence, if we're practicing evidence-based medicine, that the work that we do, that we know that does good, that is actually doing good. And then here's another study. It's a meta-analysis, moderate evidence to support the role of early specialist palliative care for improvement in symptoms, survival, health-related communication. And then pediatric and geriatric oncology don't have enough studies, they say, and there's more studies that need to be done. So in 2016, ASCO put out guidelines. Inpatients and outpatients should have early palliative care services along with active care. So if we're following guidelines, you'd think about calling us. So I kind of talked about this a little bit: physical symptom management, fatigue, sleep, mood, and anxiety, constipation, nausea, vomiting, diarrhea, poor appetite, nutrition counseling, delirium or cognitive impairment assessments, holistic or integrative medicine, things like acupuncture referrals, massage. A lot of what we do is psychological and emotional support, helping with patients how to cope. So I think if you look at some of the literature, the oncologists do a great job at controlling physical symptoms. We do get called on several patients who have uncontrolled pain and other symptoms, but for the most part, I think Dr. Fonsilis does a great job, and his colleagues, of treating symptoms. Where it's a little trickier is when patients are having trouble coping. And so that's a team-based approach that palliative really, it's kind of getting deeper and spending more time. Cognitive, behavioral, mindfulness, practical help in the home, spiritual support, existential distress, religious counseling. So these are all like really good stuff. I mean, when patients get treated by us, they walk out saying, this is the best visit I've ever had at Roswell Park. Thank you. How come you didn't see me 6 months ago or a year ago? And I'm not not to brag or toot my own horn, but patients really, really like the service once they realize that we're not going to throw them in the grave. Question 1, please pick what is true. Palliative care is associated with the following. 1, a prognosis of 6 months or less, better survival in some patients with cancer, a team approach addressing physical, emotional, and spiritual needs of the patient and family. 2 and 3, or all of the above. Huh? I know, I'm giving them a minute to think about it. Oh, you got to press it first? Okay. This is kind of fun. Okay. So, pretty good. The right answer is that it does not. So it's these two. It's 2 and 3. But prognosis of 6 months or less, I said on the first slide, is for hospice, not palliative care. Palliative care is anybody. All prognoses. Oh, how do I go to the next slide now? Oh, there we go. So let's talk about pancreatic cancer. It's pretty painful. I see a lot of people right from Dr. Bain. So Dr. Bain sent us a lot of referrals right from the endoscopy suite because his patients are writhing around in pain. So they say, Dr. Case, can you see this person today? And I say, yes, I can. So we really feel like we can do a lot of good for people. So we often see them before they even see their oncologist to help with the pain. So it hurts to have a mass in your pancreas. It causes a lot of tissue destruction, inflammation, duct obstruction, infiltration, which affects, so when we assess pain, we figure out what is the type of pain. So when it's in your organ, you think about angina, it kind of radiates, it's nondescript. That's visceral pain, nociceptive visceral. And we treat that a certain way. And then we treat nociceptive somatic, which is bone and soft tissue, we treat that a different way. And then when it's nerve involvement, we treat that even a different way. And that's called neuropathic. So pancreatic cancer is all three. Often the patients have visceral, they have somatic component because of the bulky kind of tumor in there, but Many of them actually get compression of the celiac plexus nerve bundle, and they actually have a lot of neuropathic component of pain. And so you'll give them opioids, and it doesn't work. So you'll have to give them agents for neuropathic pain, and that does work. So celiac plexus block was done in the olden days and not done as much anymore, and the studies have shown it's not really very beneficial for those with inoperable disease, can only usually result in short-term relief, and evidence-based medicine really just kind of is downplaying that now. Medications. If the platelets are okay and they're not having GI irritation or GERD or whatever, kidneys are okay, we can use some NSAIDs. I use difluzinol, which is Dolobit. You may have heard of it. It's an old school agent. Does not, in my opinion, one of the research I've done, does not inhibit platelets. Celebrex is another one, does not inhibit platelets. Most of these patients will be placed on chemotherapy that will impair their platelet numbers and function. And so if they do get placed on an NSAID, we may want to plan ahead and use one that is not going to inhibit platelets. And so they still are those two drugs are still in the NSAID category. And so some pharmacists may not know, actually many pharmacists don't know this, so they'll stop the drug if the patient, is on a blood thinner or going for surgery, and that's fine. I've stopped arguing about that. But if you do the literature search, those are the two safe ones. Tylenol. So Tylenol is often not maximized in patients, and if you do maximize it, it can actually be a really safe and effective adjuvant, or actually analgesic. And so the maximum dose in those who are healthy adults with a normal liver is 3 grams. So that was changed about 3-4 years ago. 4 is olden days, now it's 3, and it's been 3 for a while. Beer's criteria for elderly max dose is 2 grams, right? 2 grams. So if the patient is 75 or older, you're going to max dose is 2 grams. In people who have liver disease, maybe 2 grams, but healthy adults with normal LFTs, you're going to do 3,000 max a day. So I often give people 1,000 3 times a day, and that will actually reduce the amount of opioid that they will need. Opioids, they're the mainstay of treatment for pancreatic cancer. I mean, they help pain. We're not going to deny that. So methadone is our first-line agent, actually, that we use, because in my opinion, it's probably the best and most effective and least opioid that has the least side effects. So at least amount of constipation and cognitive impairment associated with that. You just need to monitor the QT, make sure they don't have QT prolongation or are on any drugs that would interact with that, because there are several drugs that interact with methadone. If you're uncomfortable using methadone, low doses of long-acting morphine or other opioids can be used. I'm happy to talk to you about opioids on a different day, or you can email me with questions about opioids. But generally, they're used. You can start someone on a short-acting to begin with to see how many times a day they're going to use that. And then if they're using it more than 2 times a day or 3 times a day, then that's a sign that they need a long-acting pain medicine. And so we usually do kind of almost like the same thing you would do with insulin. When they're taking a lot of it, you add it all up, you kind of do an equal analgesic conversion. And if you don't know how to do that, that's a simple thing we could teach you. There's tables, equal analgesic dosing tables online and readily available. There's little apps on your phone that can help you calculate those things. Gabapentin, pregabalin are 2 drugs that are used for the neuropathic component of pain. And they're, in my opinion and experience over the last maybe 15 years doing this, neuropathic pain due to pancreatic cancer responds very well to gabapentin for whatever reason. And people who have chronic pancreatitis, pain, and I think that's because of the neuropathic component of the celiac plexus. Duloxetine is Cymbalta is the other name of that one. We use this as well. There's lots of studies that show this is the first-line agent that should be used in patients with peripheral neuropathy pain. As far as neuropathic pain from the tumor, you can try it. I haven't had as much success with duloxetine when we're talking about pancreatic cancer pain, but you certainly could try it in someone who has a lot of anxiety and depression, and you're kind of killing 2 birds with 1 stone. So we start people on 30 milligrams. Nortriptyline is another really great TCA. Again, in the elderly, we have to be careful with TCAs. They can cause orthostasis, they can cause urinary retention, constipation. This is one of the better tolerated ones. I'd never ever use amitriptyline in pretty much anyone. There's no reason to do that. This is a better tolerated drug with the same amount of efficacy. And so if you look at the studies, there's a lot of studies about amitriptyline, but this drug has been shown in several studies to be as effective with way less. The therapeutic index is it's way better tolerated than amitriptyline. Steroids are very, very effective. If the person has a lot of heartburn and potential GI irritation, though, you'd have to be pretty careful, which many of our patients do when they present, because they've either been retching or they may have some kind of surrounding inflammation there in the esophagus. Or some just because they're so critically ill, they could have some esophagitis going on. And so it helps not only the visceral pain, but it helps appetite, fatigue, bone pain, nausea. So if they have metastatic lesions other places, if they're nauseous, if they're tired, which many of them are. So we put people on Dex, and then they love us because they feel amazing on it. And then I screw up your Pembro. So then, so dexamethasone, you have to be careful that the patient isn't on immunotherapy, because this lowers the immune system and suppresses the immune system, whereas the immunotherapy agents, the immune checkpoint inhibitors, the whole point of that is to rev up the immune system, and so they work against each other. It's like giving fluids in Lasix, or eating a candy bar and then taking more insulin. It just doesn't make sense. So you wouldn't have somebody on dexamethasone. However, many of my oncology colleagues disagree about whether or not dexamethasone can be given and when. There's some studies out there talking about this, but it is very hotly debated. So I usually do not give it until I've spoken with that very specific oncologist about what they want me to do. We certainly wouldn't want to make anybody upset. So that's the whole story with dexamethasone. But if I do have permission to use it, it is a fantastic way to control pain in a quick, easy way. People often don't want to stop it. In the long term, it has several side effects, so generally we do try to get people off of it, especially if they have a longer life expectancy. Medical cannabis is, I put this on the list for pain because it is something that we use for neuropathic pain, poor appetite, and nausea. Those are the three indications that we mainly use medical cannabis for. Some people, it may not actually help their pancreatic tumor pain, because that pain is pretty bad. But if you have a little numbness and tingling, neuropathy, it might help that. Generally, in my opinion, I think cannabis helps people cope with their pain better than actually helping true cancer pain. Radiation, acupuncture. So GI effects, we see a lot of people with biliary obstructions who require stents, drains. These people generally may do not as well. So prognosis-wise, if you have a drain coming out of your abdomen, you certainly are probably at a higher risk of cholangitis or some impending bad thing, right? So generally those people probably should have an advanced care planning discussion, right? Pancreatic insufficiency, that causes a lot of bloating, and whenever you eat food, cramping. That doesn't feel too good. So I could just throw a ton of opioids at the patient and snow them, and then they'll be a zombie, or I could give them Creon. I know you don't love Creon, but a lot of times they actually have inability to digest fats, and when we give Creon, then we take away their opioids because they don't need them anymore, because they're not bloating, and they were improperly placed on opioids for something that was just a pancreatic insufficiency. And many of them, if you take a history, might have fatty stools or like pale-colored stools, and I know that this can be kind of correlated with pancreatic insufficiency history. So pancreatic enzyme replacement is really important in these patients, and I pretty much put people on Creon quite frequently, and it helps control their symptoms. Acid-reducing medication also, these patients have kind of hyper secretion of acid. I think there's just a lot going on down there in that area, and so putting them on some GERD treatment can really help. Many of them end up with GOO, gastric outlet obstruction. I just left the patient's room who had one. It doesn't feel good, especially those people who love food, love to eat. It can be pretty devastating to have this happen. 26% of patients, they start out with vomiting, which makes a lot of sense. So you can stent these things. Sometimes the stents don't work out like we plan. They can become misplaced. I don't want to talk badly about stents because I think they're amazing when they work well. I just came from a bad case, so I'm just like a little bit jaded on the stent right now. But sometimes it can cause a lot of pain too. And so, stents can be helpful. They also have side effects. So it's just it's a discussion that needs to be had right at the get-go about that. They can become misplaced. But they also can help people live longer, if they can get the food down and avoid feeding tubes. Nausea. Nausea is really common. Pretty much a lot of the patients we see have nausea. And we give whole lectures on how to treat and assess nausea. So nausea is not just like, well, we'll give them Reglan and move on, We try to assess what is the cause of the nausea. Is it pain-induced? Is it chemoreceptor trigger zone from, a central issue from a medication that's infecting the thalamus? Is it a GI cause? In these cases, it's many times a GI cause. And so Zofran, works on the serotonin, 5-HT. So, some of these receptors may be just, Zofran might be enough. But in general, the best agent, in my opinion, is olanzapine. If you look at the chart of all the different receptors that it works on, it's the most amount of receptors. Whereas I think compazine works on like 1, and Zofran works on 1. Olanzapine works on like 5. So it is an amazing anti-nausea drug. And it is actually written into some of the NCCN guidelines for severe nausea and vomiting. Giving people 10 milligrams, like the guidelines say, is generally not, I don't advise that because it's extremely sedating. If the person's mildly nauseous, you can use 5 milligrams or even 2.5. If they're elderly, I usually would start with 2.5. So I think what I commonly see is people being OD'd on olanzapine and like on the floor with sedation, and then they never want to take it again. But if you dose it properly right from the get-go, then you won't run into that. Cancer-associated anorexia cachexia syndrome. This is not pretty. People who have this generally are pretty miserable. No matter how much they eat, they still lose weight. They still get pretty thin. Many of them have what we call dysgeusia. Have you heard of that phrase, dysgeusia? So dysgeusia, D-Y-S-G-E-U-S-A, is just the medical term for lack of taste. So there's papers written about this. It's pretty cool. There's a randomized controlled trial that shows that zinc supplements can help with building back the taste buds when they've been obliterated by chemotherapy agents. So patients will say to you, I can't taste food. It tastes like cardboard, or it tastes metallic or salty. So if their food tastes like crap, they're not going to want to eat. And then on top of that, they have cancer that's blunting their appetite because of all of the different cytotoxic the cytokines that are floating around in their blood, and so they get really weak. Many of them have early satiety, and so we use a lot of Reglan, and that a lot of times helps people with their digestion and their bloating and their gas and their nausea. Loss of appetite is common, decreased quality of life. So this, you can imagine that if this is going on every time you eat, that really, your life would pretty much be pretty miserable, right? So people come to us. I've had people asking me, not to end their lives, but just saying I'd rather just be dead if I can't even eat. And they're throwing up and they're in pain. And it's just terrible. But we can get these people, usually all it takes is one visit with us and we can get them comfortable. And then maybe a few follow-up phone calls within the next week, titrating meds up. So we're pretty aggressive with these people. We'll put them on methadone, gabapentin, Reglan. We'll be hitting them with, day 1, do this, day 2, day 3, and I'll write down, this is why it takes an hour, we write down all the different things we're going to do on each day. And then usually by the end of the week, we can get them feeling back to their normal self. Increasing caloric intake, small frequent meals. Megace, not loving it. It's not a great drug. Causes blood clots. That's all I'm going to say. It's not that effective. Mirtazapine, Remeron, great drug. You just have to watch the LFTs because this one can cause transaminitis and biliary elevation, triglycerides. If they have a baseline elevated LFTs, I really wouldn't even start it, or I'd use it at a very reduced dose with monitoring. Dexamethasone, we already talked about the benefits of that. Zinc, talked about that too. And then I always encourage people to use exercise as a form of palliation. And so as crappy as they feel, I try to encourage them to at least walk every day, maybe some light weights, because that really helps combat fatigue and kind of helps with their walking around with the digestion and just the bloating and all of that. Pain from pancreatic cancer is often 1, nociceptive visceral, 2, neuropathic, 3, improved with opioids, 4, improved with gabapentin, 5, all of the above. Yay! That's awesome. So it is all of the above. That's all I'm going to say about that. It seems like 92% of people. And so, you know, a lot of times we just focus on the physical when we're first meeting somebody to get them comfortable. But then once you get them comfortable, you have to get back and reassess their overall just status. And a lot of that falls to more of the mood and how are we coping and how are we functioning in life. So these two are huge, huge. I could probably have a full-time psychiatrist on my team. I do not. So therefore, I'm the psychiatrist. You know, we see people who are suicidal, who are, you know, just a mess over this. And you can imagine how devastating it is to be told you have pancreatic cancer. I mean, it's just a devastating thing. I mean, you Google it. So I had a 51-year-old or something that recently came to my clinic, and he was sitting there like this, you know, leaning back in the chair. And my nurse is like, oh, Amy, he's so pissed. He is like mad. And he like is in a lot of pain and he's spitting fire. So I went in there, you know, and it was just listening to him. And I did another thing that sometimes is missed, and it starts with an E. What was that? Empathy, yeah. So how do we empathize? You listen, and then, you know, you might reflect a little. And I'd be like, dude, you're like super pissed right now. And I'm like, I don't blame you, because this sucks. You just got the worst news of your life like a week ago, and now you're sitting here with me. So we kind of get real with people. And, you know, now he's like my BFF. We're like joking on the phone, and I'm calling him, checking on him. He wants cannabis. I'm like, all right, you want weed? You know, and it's like fun, you know. I mean, and this guy a week ago wanted to, you know, punch a wall. He was so angry. So if we react defensively to someone's anger, like because we think they're angry at us, he wasn't angry at me. He was angry at the circumstance. So we could say this guy's a jerk or a difficult patient, as I hear all the time. He's not a difficult patient. He's having a difficult situation, and that's why we need to love him even more, right? Hugs are free, and there's no side effects to them. Insomnia, this is me, I'm sorry. This is how I give lectures. I apologize if I'm kind of unhinged right now. So now we're moving on to cannabis, and this is a really intelligent slide. We're going to talk about cannabinoids, and you know, these things are drugs. They are chemicals. Medical marijuana has like 400 chemicals in it. So when people tell me, Dr. Case, I want something natural. I don't want any Dr. Christos Fonsilis' drugs. I just want something from you. All I want is your herb. And I'll say, well, let's talk about all of the chemicals that are in cannabis. And so the reason why it actually does work in many patients is that it does affect several different pathways, you know, in the endocannabinoid system, the GABA, acetylcholine, glutamate, norepinephrine. And so you could probably look this stuff up and read about it. I'm not going to read to you the names, but you know, there's two different receptors, the CB1 and CB2 that, you know, work in the CNS and then in the immune system. And so if you read about this stuff, it's fascinating, you know, CBD oil and all of that. It's not witch doctory. This stuff is real medicine. There are many studies published about benefits, and I can talk a little bit about the individual main chemicals. So THC is one of the main chemicals we've probably all heard of in the room, right? Everyone knows what THC is. So when you use marijuana recreationally, people seek that high THC. So that's the recreational product that people smoke has a high THC. So many patients, when they're seeking it recreational, want the high THC products. Why? Because it's the psychotropic effect of marijuana. They want that euphoria, relaxation. There can be a depression period after, alterations in memory, cognitive perception. immunosuppressive. Actually, THC can cause immunosuppression, whereas the CBD can actually boost. It helps with anti-inflammatory. Whereas cardiovascular effects that can occur right after taking marijuana can be a high heart rate, orthostasis, and vasodilation. So if somebody's a cardiac patient, you might want to talk to them about the side effects before embarking. Generally, you need 2 chemicals to be effective. That's called the entourage effect for pain. So you need THC in the product and you need CBD. One alone is going to really not be effective. So if you give someone Marinol, which is synthetic THC alone, it generally is a pretty poor product. And it can cause a lot of psychotropic side effects, especially the elderly. So we pretty much never use it. So appetite stimulation, anti-emetic, CBD. So it's used in very high doses for seizures. You've probably heard about that in children. Analgesics, anti-anxiety, antidepressant, antipsychotic, anti-inflammatory, immunosuppressive. So CBD tampers the effect of THC. So the two together work really well together, because if you just do straight THC, you're going to be kind of hallucinating and having a lot of psychoactive. If you do CBD alone, you may just, I don't know, it's going to be placebo effect where you might feel a little bit, take the edge off your anxiety, you might be able to go to sleep. It's kind of like the yin and the yang. So like together, they work the best. So CBD reduces the psychoactive effects of THC and improves its tolerability. But again, if you have a high THC product, like 50 to 1, I pretty much never, ever, ever recommend that for my patients. So I usually recommend 1 to 1 or 2 to 1, because those have both chemicals, but it's not overdoing it on the one that has a harmful side effect. So yeah, that's pretty much what I said there. And that's just a picture form of what I just said, that the two kind of work better synergistically, and that THC is an agonist of CB1, and then, that they work together. So products in New York State, there are products all over the country that are very different than New York State, but New York State has oils, pills, and vape. Not smoked. There's a lot of people out there that have very false information, about this stuff. So I hear it all, like, oh yeah, from New York State, you can get, joints and you're smoking them. And I'm like, who told you that? Oh, my doctor, So like, we just have to be careful that we're telling the patients the right things about this stuff. So other states have patches, suppositories, topical creams, and things like that. So if your patient is taking that, it's illicit. It's illicit. Okay, they'll say, oh, I got it from California online and it's all legal. Nope, it is not. So it's not legal to order any of this stuff from another state and have it shipped to New York. The only thing that's legal is what is your little cannabis card that the doctor certifies you for. You go online to New York State and you get a New York State card. And then what the New York State product appears on your PMP, your iStop. So everything else is illicit, even though the patient would swear up and down that it's legal and I got it from California, or I got it. And it may be not monitored at all, the product that they got online. So it could have mold in it, it could be crap, you don't know. So I usually counsel people to just get it through New York State. So the state of health, in 2017, the current state of evidence by the National Academy of Sciences put out a very large report. And this is like legit, this is the end of the story. We don't have to argue with this too much. There is strong evidence that there's benefits for chronic pain, chemotherapy-induced nausea, vomiting, and spasticity related to multiple sclerosis. Moderate evidence for sleep disorders related to chronic illness, and only limited evidence that it improves appetite, but this is only in AIDS patients because all the studies were done in AIDS. So there's not a lot of literature on appetite, so that's what we're going to study here. We're going to study cannabis, and we're going to look at it for all different things. Anxiety, PTSD, and depression has limited evidence. However, in my clinical experience of using this product on hundreds of patients, I feel that this is the best, this is where the money is with cannabis, because people's pain and their depression is very tightly linked. That's why some Balta helps pain. You've seen the commercials. So these patients tend to, when I give them cannabis, they'll say, Well, I still have the pain, but I don't care about it as much. I can sleep better. I don't lay awake worrying about it because I'm chill. So it's not actually helping the pain, it's like helping them cope with the pain. Does that make sense? So if someone has a tumor eroding into an organ, but they're like not having any anxiety and they're like actually just like really in a lot of pain, but they're not freaking out, this actually may not be the end-all be-all for that patient. It's the one who's freaking out that needs cannabis. The one that's really having a lot of anxiety. And you'll know who that patient is. Those are your chemical copers, the one who's drinking to cope, the one who's taking more of their oxy to cope. Give them the cannabis. They'll do well on that. And take away the oxy, to be honest. Well, maybe not always if it's a pancreatic cancer, but if it's non-malignant back pain, the governor says to take away the oxy. Anyways, no evidence that it cures cancer yet, although there's a lot of talk about putting cannabis in petri dishes and seeing what it does to the cells, which, yes, it does kill the cells. But in human studies, there is no benefit on the cellular level. There are a few little studies that show that cancer cells may die if you put cannabis in the petri dish with it, okay? So because of that, if you get diagnosed with cancer, your Gmail inbox will be flooded with, take cannabis, it will cure your cancer. Order it online right now from California. And so this actually happens. That there are people who find out somehow that they're cancer patients and they get marketed to. It's crazy. So there was a few studies that I'm just going to put up here. And am I running out of time? No. One is Cochrane database review. So when people tell you, oh, there's no evidence at all about medical cannabis, that's not true. There actually is evidence. There's some. There's not a ton of studies, but there are some pretty big, decent studies. So this one was a Cochrane review that looked at 1,750 subjects, 16 different studies looking at several different products. The problem with these studies is that all the products are kind of different and the dosing is different. So what the lack of evidence, when people are saying there's a lack of evidence, and if you look at the media and some of the literature about this, the people who are like very anti-cannabis will say there's no literature, there's no quality adverse effect studies or dosing studies. So there's a lot of research to be done still, but the general benefit of cannabis has been studied. So the number needed to treat was 20 to have an improvement of 50% or more in pain improvement. And the number needed to treat was 11 for a 30% improvement in pain. Not super great, but it's better than, And so the number needed to harm was 25 for adverse effects. So that's not that great either. Like people actually do have adverse effects from this. And so you have to talk to them about that. And there's another big thing you have to ask people about when you're starting them on cannabis. Can you think of what that might be? Like it would be a contraindication. If you think about the psychoactive effect of cannabis and what it might do to you. I hear mumbling. We have a psychiatrist in the room. I'm not going to pick on you. Someone with a history of psychosis. So it will trigger psychosis in somebody. So you have to ask about mental illness, maybe bipolar, and a history of maybe a psychiatric hospitalization or any other hallucinations in the past. And that's another thing like that people don't want to ask about because it's a touchy thing to ask about. But it is really important to talk about. This study looked at, it was neuropathic pain, 15 randomized controlled trials. So look, there were randomized controlled trials out there on this. And so there's these different products they used, and they felt that the number needed to treat in this study was 14 for a meaningful pain relief of a cutoff of 30%. JAMA, whiting, this was a big one, 2015. This was 28 randomized trials, almost 2,500 participants, and they looked at a bunch of different symptoms that may benefit from cannabis use. And again, different products in each study. One of them, all but one of them, used a placebo control, while the remaining trial used an active comparator. So those who reported 30% improvement of pain, the odds ratio was 1.4, which is statistically significant. And then one trial, the patients reported the greatest benefit with smoking. And then significant adverse events, SAEs. Those patients, some of them had some serious withdrawal, that they reported serious adverse effects. So some people have, confusion, delirium, they may crash up a car, they might feel altered. So those are the kinds of things that can happen. There's another adverse effect that is pretty important to know about with cannabis, especially the high amount in buffalo of illicit use. So someone presents to you and they're like, blah, 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 vomiting like crazy, and they just took paclitaxel or gemcitabine or whatever. So you could say, well, it's from your chemo, or you could ask them, how many times a day do you smoke pot? And they'll say, continuously. And then you'd say, you have. So there's a syndrome called hyperemesis of marijuana use. And so I've actually seen this a bunch of times because a lot of the marijuana people come to our clinic looking for medical marijuana, and many of them have the hyperemesis of cannabis. And so basically it's like if you smoke marijuana, it does something to the brain where it can actually induce nausea and vomiting. So even though it helps nausea and vomiting in some of the patients, you can overdo it. And so when you take a hot shower, for whatever reason, that's supposed to make it better. And then when you stop using the cannabis, believe it or not, that also makes it better. Can you imagine that? I'm sorry, it's just like. And so I had a young kid, an AYA patient, who came in and he was like, I'm throwing up constantly, I think I need medical cannabis. I'm like, well, are you taking it? I'm smoking it continuously. So I said, you have hyperemesis syndrome, so you need to stop. And I'll give you medical and see what happens. It went away. His nausea and vomiting went away. So it was, he like came to me, he was like, oh my God. He's like, that was the most awesome advice ever. And he still smokes it, of course, he still smokes it, but not as much. He learned to chill out with how much he's smoking it. CINV, that's chemotherapy-induced nausea and vomiting pain. And so 30 randomized controlled trials. They found that cannabinoids were more effective anti-emetics than compazine, metoclopramide, thorazine, and haloperidol. And the relative risk was 1.38, number needed to treat was 6, and for nausea and 8 for vomiting. So let's keep going. No head-to-head comparisons with some of the NKI inhibitors or the 5-HT receptor antagonists. And, there's not a lot of randomized controlled trials with use in advanced cancer. And so generally I'll use olanzapine before I would ever use this. And it's also pretty expensive. So we're going to do a question. 1, pick the false statement. Cannabis has been shown to be effective for neuropathic pain. 2, patients may be certified for smoking medical cannabis legally in New York State. 3, medical marijuana is not covered by insurance. 4, medical cannabis may cause delirium. Yeah, look at that. That's good. We don't want people smoking it. It hurts their lungs. So we have a few minutes left. I'm just going to wrap up, but I'm going to do a few slides on advanced care planning. And I'm sure you all probably know what a MOLST is, that hot pink form where we fill out a DNR order. And, I have some clinics here that don't even stock these, but, it's really important to kind of get familiar with this form and how to fill it out. Living wills, power of attorney. Living wills are done by an attorney. They don't mean anything as far as what's done to someone's human body. All they are is a document that states someone's wishes, but a DNR needs to be filled out, which is a MOLST form, if you want to make sure the person doesn't get resuscitated. So prognostication is something that's often missed, but we teach this. I write book chapters about it. It's something in palliative we talk about quite a bit. And why is that important? Because a lot of times it factors into figuring out how someone might do and how can they benefit from our treatments. And so in general, patient and caregivers want to discuss these things. They often get relieved when we bring it up. They want to negotiate how much is shared and the content, so it's often very important to ask them how much they want to know. And as their disease progresses, in general, caregivers want more info, and the patients usually don't want as much because they already kind of know, and they don't want to get hit over the head with the truth stick, I say. So they prefer a professional who they trust, who they shows empathy and honesty, encourages them to ask questions, and clarifies understanding, and that was studied. Surrogates want to discuss prognosis even if it is uncertain, and so saying things like, I wouldn't be surprised if things got worse in the next few months, or something like that, but some people might live longer or die sooner. They feel that it leaves room for hope to discuss these things. It increases trust in the physician. They feel like you're being real with them instead of glossing over the truth, and signals the need to prepare for possible bereavement. So truth-telling. So providers feel patients should be told the truth in practice, but may avoid or withhold. They're worried that their police might come after them, if they're incorrect. And the patient will lose confidence. They are afraid of taking away a patient's hope or faith. There's uncertainty, which none of us docs like, or healthcare providers like. We like black and white. We like statistics. We like to look up the right answer. Heaven forbid we could tell someone something that could be slightly wrong. Lack of training. No time to attend to someone's emotional needs. You drop the nuclear bomb and then you walk out of the room and they're crying. Well, you gotta call Dr. Case because the person needs this to be addressed. This needs to be addressed. Stress. It's stressful to talk about these things. Really high rate of burnout in oncology and palliative care. So I'm gonna wrap up. Requests from family to withhold information, fearing that that the patient's going to feel that you're inadequate as a physician. And in multiple studies, it's shown that physicians are highly inaccurate when talking about prognosis by a factor of about 3 to 5. This has actually been studied in the optimistic direction. This study, I'm not going to go through because I'm running out of time, but this study showed that patients generally are inaccurate by a factor of 5 to 3, and the longer you know the patient, the more incorrect you actually are at making a prognosis. Oops, I just gave you the answer. What % of patients who survive to hospital discharge after CPR? And this is like all comers, not just those with cancer. Right, so only 17%. It's meant for healthy people who have a cardiac arrest. 17% survival to discharge, and those who are elderly or have advanced cancer only survive, those are elderly 5% and 2% with advanced cancer survive a CPR situation. And so when you tell people the truth about those statistics, when the study showed that before learning the true probability, 41% of people wanted CPR. After learning the true probability, only 22% wanted it, but they were asked if they had a life-limiting illness, then it went down to only 5% wanted it. So that just goes to show that knowledge is key, and it's up to us to give them those information, those data. And I have a video, and unfortunately it's about 3 minutes, and I think I probably talked too much about cannabis. This video is way better than cannabis. But anyway, spikes. How do we talk about these things? Check it out. The slides I think you probably have in your handout. The spikes is really an important way to have a discussion with a family and a patient, and making sure you're sitting down. It's a private area. The proper people are invited to the meeting. You find out how much the patient understands. You ask their perception. You invite yourself, how much information would you want to know? And then K is knowledge. Don't you talk forever about big words, and just give the big picture. Your cancer's advanced. It's metastasized to these places, and this is what I wouldn't be surprised if your prognosis is X, Y, or Z. Then we have to be real careful to be empathetic and reflect the emotion. And at the end, strategize or summarize. And then here's another mnemonic about empathy, which is really beautiful. So some of the things that, and this is I think like my last slide, some of the things that we say is to ask, tell, ask. Ask, knowing you may have a short time left, where would you want to be and how would you want to spend your time? So it doesn't have to be threatening. You don't have to say, right now you have a short time left. You could say, if in the future down the road you were facing the end of your life, kind of down there, what's important to you? Where do you want to be? And, 98% of the time people say, I prefer to be home, I don't want to suffer, don't want to be in a machine. And I'd say, okay, so then what I recommend is we do everything for you to prolong your life while it still makes sense. We'll still do chemo, we'll do surgery, if it makes sense, we'll do all those things. But what we wouldn't probably do then is shock your heart if it stops or put you on a machine, because those things are not likely to help you. And it definitely would not mean you'd be at home. So this is what I recommend. We'll fill this out and we'll say that we're going to treat everything, but we're not going to do those other two things. And so if you do it that way, people are they're fine with it. If you ask someone, do you want your heart, do you want to live? So I've actually seen attendings ask if someone wants to live. Or asking, do you want your heart restarted when it stops? Without any education, without any discussion. So you could see where that is really super problematic. So if the goal is to be home and comfortable, make a recommendation. And if people say, yeah, I want to be shocked, give me everything you got, I might ask more probing questions. What do you expect is going to happen? Someone told me the other day he had gastric cancer, he's 72, he's had it for a while, and now he had a JG tube put in, and basically he's going home and he's got intraperitoneal mets. And he said, I'd take about 2.5 years on a ventilator. And I gently just kind of asked him more about that and kind of repeated those statistics I showed. And, people with advanced cancer who were in their 70s wouldn't ever live 2 years. That just would never happen. People die when they're that sick that they would need ventilatory support. So if you ever get that sick, that you wouldn't even make it that far. And when we talked about all that, just very honestly, he was like, oh yeah, I would want that then. It wasn't anything, if you leave it at the 2.5 years and he has no clue the reality of what he's asking for, because we're too afraid to tell him the truth, then he'll die in a vent in the ICU. All right, so we're done. Making a recommendation is really important. And so here's some statements that are in your book here that can help you maybe, make a recommendation for people.